Well, good afternoon, everyone. I'm grateful for the opportunity to participate in this workshop today and do this very important work of this time. What I'm going to talk about today is ethics as it relates to policy, practice, and essentially prosecution. And unlike my colleague Sid, I'm very much not retired, so I have to say that the work that I'm going to talk about today represents my own opinions and not those of the Justice Department. So to get started, there are a number of issues on ethics that I'm going to speak about. The first is goals and ethical principles in practice and research. The elder justice concept map, which is something that many of you know about and I'm sure have been involved with. Ethical issues in a number of areas. One is decisional capacity, informed consent, reporting. I'm going to also talk about HIPAA, which Dr. Lax and others have bandied about, I think, and it's an important issue to focus on. And finally, what Secretary Greenlee and others talked about this morning, which is healthcare prosecution as a vehicle to really assist and combat elder abuse, particularly in the long-term care setting. So when we start out and we talk about ethics, what are really the goals of the ethics that we're trying to reach here today? One is to prevent unnecessary suffering. A second is to maintain autonomy. And many people today have talked about that. I know Alexandra spoke about autonomy early this morning. And autonomy involves questions of decisional capacity, and that's clearly been a key issue. And finally, James O'Brien hit on this just a few moments before the non-break transition, which is maintaining quality of life, and that's obviously a very important point. I know that Dr. Dong, I believe it was a few years ago at GSA, focused on some ethical principles. And there are 4 ethical principles that really drive some of the issues that we're going to deal with today. And of course, one is autonomy and self-determination. A second is justice, you know, the obligation actually to be fair to all people and to do what is right. A third is beneficence, requiring healthcare providers to do good. And doing good in the context, basically, of an individual's beliefs, their feelings, and their individual perspective. And then finally, non-malfeasance, you know, to do no harm, but also to extend that to actually, you know, prevent individuals from coming into harm's way. So in trying to decide which ethical issues to focus on, we took some instruction from the concept map project that the Department of Justice has been engaged with the funding from HHS and working with the Concept Systems, Inc. And as I said, I mean, this project, I'm sure, involved many of you in this room. We started by inviting 750 professionals from the field to comment and to answer the following question: to understand, prevent, identify, or respond to elder abuse, neglect, or exploitation we need. And so then we filled that in to try to decide, you know, what are the critical issues here. And in this brainstorming phase, we generated a number of ideas. And some of these ideas are what are really framing my discussion here on the ethical issues. And those are brain health and function, i.e. decisional capacity, elder abuse reporting, HIPAA, and quality in the long-term care context. So moving to decisional capacity, you know, my colleague Jason here is going to discuss that in detail, so I'll just hit on a few definitions we should keep in mind. And one is, obviously, decision-making capacity is the ability to understand the nature and consequences of different options. But what's important to keep in mind is decision-making capacity is obviously required in order to give informed consent, but it also may fluctuate over time given you know, the state of health of a particular individual. And it also may be specific to a particular issue. So does an individual have a decisional capacity on a particular issue, and will that change as their health obviously changes? Another issue that came up, and I believe it was Gil's point, was this notion of competency. Competency, being different from decisional capacity, talks about a legal determination as to a mental disability or incapacity. And the law here in the United States, of course, presumes that adults are competent and have decision-making capacity to make health decisions. And the question was raised, well, why do you need to go to court? And I think what we need to think about is, in protecting elders, particularly from financial exploitation, is the idea that somebody may decide, for example, that they want to transfer say someone taking care of an elder decides, well, gosh, I've been caring for this person for, a period of months. They have a very nice house. I'd like to transfer, that house into my name or something to that effect. To make a change in a legal document, without the signature of that individual, there would have to be some sort of statement that that person was not, capable of making that decision. And for that reason, a lot of times you go through the court, get a guardian. The guardian makes a determination on that particular transaction, and the court makes a determination on capacity. So for reasons of protection, those decisions are important to be made. Moving to the question of how does decisional capacity affect research and actually the legal system, I turned to Secretary Greenlee's point early on. Capacity in the legal system is important for the vulnerable adults, and that is because, of course, the question of whether or not somebody can be a witness is one of competency. And if an individual is not, competent and doesn't have appropriate capacity, they can't be a witness in a case. And as a number of people have written about in the legal literature, sometimes that's a defense strategy. If there's a witness who's particularly powerful, or an individual or a complaining witness, perhaps the defense strategy to the perpetrator would be to say that that person is not competent. And that is something that needs to be examined. I know Dr. Laura Mosqueda looked in, and I believe it was a study in January 2012, about the ability of people with diminished capacity, dementia and so forth, to basically be able to testify about issues and to consider issues. And her conclusion was that you could be a witness for emotional events and psychological abuse in some of these cases. Moving now to the issue of informed consent, and this is obviously an important issue. Informed consent is required before participating in a study or consenting to any proposed treatment. And of course, the definition of informed consent is once you're given information, you have to have the ability to make a choice, understand and appreciate the issues, rationally manipulate the information, and make a stable and coherent decision. And of course, as elders move through their process of aging and perhaps having capacity deficits, there are things that affect the ability for informed consent, such as vision deficits, the ability to ask questions, and also just the perspective of saying, the doctor, there are those who believe that it's the doctor's choice just by their own cultural values, or, in the case of my parents who are World War II generation in their 90s, they believe the doctor makes the decision. So those are things that we need to sort of keep in mind. One important ethical issue in informed consent was raised today as well, and that's about multiple drug use and what has been termed in the literature, and certainly what we look at in some of the False Claims Act cases at the department, is medication abuse or overuse of antipsychotic drugs. And there's two particularly important issues to raise, ethical issues that are raised in the context of informed consent. One, CMS is trying to address this through a national initiative. And then second, there's legislation that is looking at this as well. And I'll highlight these as areas of ethical concern involving informed consent. So the first, CMS has developed a national partnership to improve dementia care through reducing antipsychotic use in nursing homes. And this is a collaborative involving state coalitions throughout the country. And they're basically trying to reduce antipsychotic use, taking December 2011 as the base and saying that they want to reduce the national rate of long-stay residents 15% from what is now a 23.9% number. And there are high prevalence rates, as you know, of antipsychotic medication in nursing homes. And again, the problem is for dementia residents. And the thought here is that, that there should not be this decision that dementia residents will be cared for because of behavioral problems by using antipsychotics, but rather should look at individual plans, look at behavior modification, and not antipsychotics. And so the goal is to reduce antipsychotics in nursing homes. And I should also add that when we get to the discussion of prosecution, this can be one area where the Department of Justice will look at the quality indicators and say, basically, that a particular long-term care facility has sufficiently flagged above the nation and above the peers that this could be considered an area of elder abuse and also of a false claim to even submit a claim for payment in a facility where there's that kind of disparity. There is a legislative agenda as well involving antipsychotic use and involving informed consent. And I think it was in 2012 that Senator Cole, Grassley, and Blumenthal basically introduced a bill that would require federal regulators to have standardized rules to get informed consent from individuals before prescribing antipsychotics that are in this black box area, black box being that they're not intended for use for dementia residents, and in fact, as the studies show, they can be particularly harmful. This proposal has been picked up in other states. I know something was just introduced in Massachusetts in January as well to get at the ethical issue of informed consent and the overuse of medications. Moving on to the next ethical issue, which involves reporting, and I know that Gil discussed this as well. She talked about reporting is not at the level it should be, and everything. There's a high degree of under-reporting, and I think there's two different practical issues here. And in the interest of time, I'll focus on the provider issue in terms of reporting. Now, we all know that there is mandatory reporting requirements in most states for a whole host of individuals on a state-by-state basis. Primarily, we're focused on medical professionals, healthcare professionals, mental health counselors, service providers, and all government agency employees, basically, who come in contact with the elderly. And so the practical question is, how do we increase reporting and get it to the point where it should be and more reflective of what's really truly going on? So the first question is, to report elder abuse, we of course have to sort of know what it is. And there have been a lot of discussion of definitions of elder abuse today, and the ones that have come up and have been represented primarily are the psychological, physical, sexual neglect, be it self-neglect or otherwise, and financial exploitation. So the individual, the provider, needs to be aware of the definition, see elder abuse, be aware of the laws regarding reporting, and then have knowledge and understanding of the next steps. And this is a point that Dr. Lack raised in the Elder Justice Coordinating Council meeting back last fall, which is, if you have a doctor in the ER, and they recognize potential signs of elder abuse, then what? I mean, is the individual to be taken from their home? Where are they to be placed? What do they do next? Take a different situation, the case of someone who's in the psychiatric home health nurse who goes into a home and who sees some of these things that were talked about today. They see someone who's, the two 90-year-old individuals, and one is starting to become demented, and they're taking care of another who has Alzheimer's. That's a problem, but what do they do next? So in those cases, there need to be solutions on that end so that there can be a determination as to incent reporting. To just talk briefly, in a research study, obviously, to the extent that someone becomes aware that an individual within that study is being abused, obviously there is a reporting requirement, and also there's the idea that writing into the study protocols for if that were to occur is important as well. I'd like to talk now about HIPAA. And the slides will be available, so I'm not going to read through each provision of HIPAA. But another important area that has been talked about is, does HIPAA basically present itself as a barrier to reporting and prosecuting elder abuse? And certainly at the Elder Justice Coordinating Council meeting, there was a lot of discussion about how HIPAA really is a barrier. And I know Dr. Mosqueda talked at length about how it's a barrier to sharing information between EMS and state prosecutors. It's a barrier to basically sharing information between hospitals and law enforcement and so forth. And I think that there is some of that, but we maintain at Justice, and we've talked about this, that the problem in large part is education about what is HIPAA really says, and a public education campaign on that score, as opposed to changes in HIPAA itself. And I think what we need to focus on is the law enforcement exceptions, and there are law enforcement exceptions to HIPAA, and I've listed a number here. I think you can take a look at the slides. They're what is required by law, as permitted by a judicial officer, obviously if you have an order, if you have a purpose for identifying or locating a suspect, and then two that are obviously important to us here in this room, which are victims of a crime, or if you are victims of abuse, neglect, or domestic violence. And so that is the place in HIPAA where the reporting is permitted. And I will say, you can look at the fine language, and it's got to be 1, 2, and 3, and it can't be 4. And there's some thicket in there, but ultimately there is a law enforcement exception which permits the sharing of information to support reporting and prosecution. And finally, turning to the issue of healthcare fraud prosecutions and remedies. So what can we at the Justice Department do to advance, in my section, the goal of elder justice, and that is to bring cases under the False Claims Act, which should be there. And those are, of late, worthless service prosecutions under the False Claims Act. And I mentioned here, the False Claims Act is a federal statute which basically our section brings to a civil False Claims Act statute for anybody knowingly presenting or causing to be presented a false claim for payment. And then, if that occurs, then there's liability for treble damages for each false claim. So how does this work in the context, essentially, of elder abuse? We bring worthless service cases, and our theory is that if a provider, let's take a long-term care provider, is providing services that are so bad that it is an actual fraud on the government to present payment to Medicare or Medicaid. Well, what is so bad? Well, we look at the bundle of services that the government is paying for. We're paying for, appropriate care. And when that care is bad in ways I'll describe in a moment, then we bring a worthless services case and a fraud case, and we've had success in that area. And how do we define sort of what is that type of bad care? It is in facilities such as nursing facilities, assisted living. We have brought these in board and care facilities and in psychiatric hospitals. And we look at systemic issues. Is there a systemic problem in this long-term care facility? Is the staffing so out of whack with the acuity of the resident that these residents simply can't be appropriately taken care of? Is the census pressure at the corporate level so high that there is no way that that bringing in these many residents with that high acuity could possibly be appropriately taken care of? And then, are basically the reimbursement mechanism such to get a facility to bring in as many residents as possible and not care for them? The type of outcomes we look at are bad outcomes such as pressure ulcers, excessive falls, excessive use of antipsychotic drugs, all of those indicators that we can look at and determine if a facility really is not doing what it should be doing. What is our remedy? At that point, we have money damages, but more importantly, we have the injunctive relief, and we are able to go in and put a long-term care facility or similar type facility under a corporate integrity agreement, which basically requires them to look at their systems and try to improve. So just in closing, to sort of to sum up, what do we need to do going forward? I take Kathleen Quinn's point, which is we need more evidence, and where appropriate, we need more prosecutions. And our section needs to look long and hard at some of these cases to make sure that elder abuse is being prosecuted where, in fact, the case warrants it. So thank you.